Welcome everybody to Grand Rounds of Rehabilitation and Movement Science for April of 2024. So this month we have two of our graduating residents presenting to us. One is Dr. George Fischer. Dr. Fischer earned his Doctor of Physical Therapy from DeSales University. He's currently a resident in the St. Luke's University Health Network Neurologic Physical Therapy residency. Throughout his career, Dr. Fischer has developed an expertise in using neuroplastic principles to enhance his patients' care. He currently works with outpatients at physical therapy at St. Luke's at 8th Avenue and works with inpatients at St. Luke's University Hospital Bethlehem campus. We also have Dr. Gabriel Lamm. Dr. Lamm received his Bachelor of Science in Sport and Exercise Physiology and Doctor of Physical Therapy both from DeSales University. He is also a current resident in the St. Luke's University Health Network Orthopedic Physical Therapy residency. He believes in enhancing movement through an active, hands-on approach, individualizing treatment to each client's needs and goals. In addition to his passion for helping others through physical therapy, Dr. Lamm is a passionate golfer and disc golfer. He has been involved in the disc golf community for over 10 years, seeing many of his own friends and community members be limited in their ability to participate in disc golf due to lingering pain and injuries. As a practicing physical therapist, he has seen and treated numerous disc golfers, inspiring him to work on injury prevention screening tools, and this presentation to help disc golfers from all over get the best care possible and return to the sport they love to play. So make sure that you sign in to EADS either using the QR code on the screen or the login information on the screen. I also copied it into the chat box in case you missed it on the front screen. This is our statement of need, and the target audience is to all providers. This is our designation statement, and none of the planners or faculty or presenters have any financial relationships to disclose. Make sure at the end of the presentation you complete your quiz and your course evaluation so that you make sure you get credit for it. And any questions, please feel free to reach out. So without further ado, I will turn it over to Dr. Fischer, implementing neuroplastic principles in patient care.
Thanks, Steve. Good afternoon, everybody. Thank you for joining me both in person today, and if you can make it online as well. I'm going to be talking to you guys about some of the latest research coming out and classifying and kind of encompassing a lot of the components of care that we bring to patients, both in the inpatient and outpatient setting, from a rehabilitative standpoint, who are not only dealing with injuries to their brain, as you'll see, but other neurodegenerative diagnoses. And what's kind of highlighted and outlined my care and how I frame my treatment strategies with patients. So these are our learning objectives for today. We're going to discuss what are considered the current 10 neuroplastic principles as they relate to motor learning. We're going to discuss the optimal motor learning theory and its applicability to patients spanning across different age spans and populations. And we're also going to work on identifying the use of these principles in different areas of practice and show how they can help to maximize your patient outcomes. You might ask yourself, what is the term neuroplasticity? What does that mean? How is it relevant to my practice? It's basically how our brain learns. We can retain infinite pieces of information. There's been no research published, to my knowledge currently, that has a limiting capacity on our brain's ability to learn and retain knowledge. Neuroplasticity is simply a neuron's ability to alter their structure and function based on some sort of stimulus. So whether that be internalized through our own self-reflection in learning and reflection on experiences, as well as external stimuli such as changes in the environment and how they kind of interact with us. So they can be characterized as internal and external stimuli, and we go through more characterizations such as sensory, cognitive, and behavioral experiences. Why does understanding this matter? If we understand how our brains learn most effectively, we can create more specific patient treatment approaches. We can improve the outcomes of those patients and ultimately, their quality of life, which is why we're here at the end of the day. So I took a while in picking out the exact image that I wanted to present here. This is a DTI fiber tractography. It's basically an MRI from the brain, and with certain contrasts used to highlight the myelinated tracts of the brain. But I think it does a great job with the different colors involved of highlighting all the different connections across the brain from different areas, and really shows the interrelatedness of the different pathways of the brains. I mean, there's infinitely many pathways, and I think it can highlight, how we learn as individuals, whether that be from a traumatic brain injury or a stroke, but also working through neurodegenerative diagnoses, trying to capitalize on certain pathways and emphasize some pathways more than others, with considerations of the athletes too, tapping into those pathways that are most specific to specific motor patterns and skill sets in their sport. So we're going to take a little bit of time to discuss the 10 neuroplastic principles today. These were kind of characterized and presented by Klein and colleagues in their 2008 publication, and there's been a lot of research tapping into these, such as use of the optimal motor learning theory within the last decade or so. The 10 principles are listed up here, as we're going to get into them into a little detail as we go along, but you'll see that they really kind of build upon one another as we go through principles 1 through 10, and they're very much interrelated. So the first principle is use it or lose it. And this refers to neural connections within the brain. They degrade if we don't use them regularly. So somebody may be recovering, somebody may sustain an injury. They may have lack of use of a hemiparetic limb following a stroke, which is the easiest example. When we look at people from a sports standpoint, they may undergo a torn ACL, and they might be immobilized with that leg for a certain number of weeks to months, whether they have surgical intervention or conservative intervention. But that lack of use leads to further degradation of these connections in the brain. We become rusty with our movements, if you will. This can be detrimental, from skill sets overall. When we look at going into training from that standpoint, use it or lose it really characterizes adding constraints to our training and really trying to focus in on what's the task to be worked on, what task do we need to focus on improving. This goes into the second principle, use it and improve it. Simply put, training increases brain representation of a skill, both on a neurotransmitter level, but also the size and recruitment in the area of the brain. When we look at it from a functional MRI, those areas in the brain, the areas of activation, they grow, they're more defined, they're larger. This can happen in a number of ways. We can have cortical reorganization, which the different cortices, the different tracts in the brain, they might be realigned or reconverted in a way that carries over to a specific movement. You can have synaptogenesis, which is the creation of new synapses in the brain, new connections. And you can also see an increase in synaptic responsivity, which basically means at those synapses, more neurotransmitters are flowing or being released to increase the amplitude of that signal. When we look at neuroplasticity, specificity matters. You've heard the term practice how you play. This is applicable to athletes, but also patients in the neurologic setting. We tend to benefit from learning and practicing more skilled novel movements rather than repetition of an old skill. It takes a lot more energy to learn skilled, more novel movements. We go back to the point of specific experiences create specific brain changes. Repetition matters with neuroplasticity. We see that continued performance of a skill over time leads to consolidation. But we also want to keep in mind the phrase repetition, but without the repetition. And what this means is that not necessarily practicing the same skill over and over and over again, but adding small novel changes to progress the way that somebody adapts and integrates that skill, consolidates that skill. There's a term that's used, it's called skill instantiation. And this is the resistance to skill decay, which ultimately means that the more that we use this skill, the less likely its risk is of decaying and us losing the skill. Intensity matters. Consider long-term potentiation of a synaptic connections in our brain versus depression. When we talk about intensity, it can be characterized in a couple different ways. You might look at, with a weightlifter, for instance, progressively loading, whether it be through repetitions or the actual resistance, the amount of weight being moved. We like to also think of it as the amount of work being performed in a series or a set period of time. Other areas where intensity can be increased is the cognitive demand as well as the environmental characteristics. So all of these different aspects of an intervention with a patient can increase the long-term potentiation of those synapses for them. Time matters. Plastic changes in the brain take time. I've listed the timeline of learning up above. Ultimately, the most effective ways that we learn can be traced back to how our genes are expressed through gene expression. This has an influence in the connectivity of how synapses are formed in our brain and ultimately how we form motor maps or motor plans. So going back to patient care, figuring out how patients best learn and taking into account these principles can ultimately help to improve their plasticity. If you've spoken or heard of Dr. Ackerman and his lectures that he's given regarding patients post-stroke, he always emphasizes the phrase that time is brain. And this refers to the amount of time from a patient's displaying stroke-like symptoms to whether they get to their arrival at the hospital and what sort of medical intervention they gain. I like to kind of rephrase or paraphrase the term in the sense of neuroplasticity. These plastic changes take time, but at the same time, in the context of a treatment session, I've found that using these neuroplastic principles and capitalizing on the specificity of the interventions that I'm doing, you can see these changes from session to session with patients too. Salience matters. This is basically how meaningful is the intervention that you're doing with the patient. What's the patient's end goal in mind? How does your intervention relate to that patient's end goal? And what specific context of that goal is that addressing with them? I have a diagram listed here. It's called the limbic system. Another term that I recently read in the research that I like to think of too, it's a good alliteration. It's called the salience circuit. It ties into our limbic system, which is ultimately our brain's center for emotional regulation. So if we're able to tap into a patient's emotions, why coming to physical therapy or why coming to rehab is important to them, with patient-specific interventions that's emotionally important to them, we can help with neuroplasticity. Age matters. As we age, unfortunately, we see that atrophy occurs in the brain. Atrophy occurs in our neurons, the white matter that facilitates synaptic connections. So something that was posed by Klein and colleagues is that, could plasticity or neuroplasticity that we see be a compensatory adaptation to aging and our body's response to the free radicals? Is that an adaptation that's happened through evolution over time? Can we capitalize and use these neuroplastic principles to help slow the aging process, both from a physical standpoint for patients, but also from a cognitive standpoint? They have noted in research that older neurons, unfortunately, are not as resilient to metabolic stressors. So we see patients with anoxic brain injuries, traumatic brain injuries, strokes, hemorrhagic strokes. They're typically more prone to having more of a difficult recovery or road to recovery ahead. Transference. This is training one circuit in the brain that can help enhance the development of another circuit. With the diagram I've shown, I think it's a good representation of, some people call it the domino effect. So if we're able to tap into one series of circuits in the brain, one connection, one motor skill, that might lead to the development and the improvement in other motor skills. And then finally, interference. Neuroplasticity is not always a good thing or a productive thing for that matter. It can also interfere and impair with learning. When we talk about a patient post-stroke for that matter, in the time that it takes them to either be hospitalized and initiate rehabilitation, or if they sustained a stroke, they haven't sought out medical care yet, and they come and see us, they might have learned behaviors over the time to be able to compensate and deal with whatever physical impairments they might be having. When we look in the context of an athlete, somebody dealing with some form of musculoskeletal injury or an overuse injury, it can be more or less of the same thing. They find a way to work around the issue that they're having, but it cannot necessarily be the best of habits. So those are the 10 neuroplastic principles. We're going to be getting into what's called the optimal motor learning theory next. And this theory takes into account pretty much all the neuroplastic principles in how we can kind of create and tap into the meaningfulness of interventions for patients to help them best learn. So optimal stands for optimizing performance through intrinsic motivation and attention for learning. Wolf and colleagues kind of coined this term, as well as the diagram that you see pictured here. We're going to go into it with a little bit more detail, and it's basically relative to three different components of the way we address our patients, or the way that we kind of angle our approach towards them, or angle our communications towards them. Terms are autonomy, patient autonomy, the freedom that they have, or the freedom that they perceive having in an intervention, enhanced expectations, the goals that we set for patients alongside them, and an external focus. This external focus is important when we contrast it with internal focus in the context of taking the focus off of the patient and themselves and their body and directing it more out into the environment. So this was more of the recent articles published by Wolf and colleagues talking about optimizing motor performance using the optimal theory, and some findings that they found through additional research articles that are out there that kind of capitalize on findings and their recommendations going back to the diagram that they've shown here. So we're going to go into that a little bit. So enhanced expectancies, as I went into, is setting goals alongside the patient and defining what does a successful task look like? What does an accomplished task look like based on what you're trying to accomplish with them? Setting this expectation early on gives them an understanding of what we're looking for in our session. What Wolf and colleagues found was that through their research, early and frequent successes are important to show for the patient, both for buy-in as well as improving their self-efficacy. And providing a sense of accomplishment for them leads to that sense of investment. It's important to maintain a challenging but an achievable atmosphere for them, and portraying a sense of progress. When we talk about autonomy, we see that a patient's influence in their actions enhances the expectancies and outcomes of the treatment and their recovery overall. Some of the research that they showed is that even seemingly irrelevant choices of picking a color of a certain device, or a cone involved in an intervention, or starting off with one intervention versus another can make a big difference in performance. And we're going to go into some of those articles in a moment. And it's important to ultimately give patients a sense of an aspect of control, because it shows and it helps them understand that they do have an investment and a hand and an influence in their care. With regards to external foci, this, as I was kind of referring to before, is an area of concentration outside a person's body or their body schema, how they perceive themselves. This can be relative to their movement efficiency, the timing of the movement, fluidity, and stamina, which can all benefit from this external versus internal foci. What Wolf and colleagues found through their research was typically in experts versus novices, with novices tended to do better or improve, and their motor learning tended to excel when they provided proximal external foci versus distal external foci. So if they gave proximal focuses that were outside of the patient's body when negotiating, let's say if they were doing an agility drill, focusing on the things that were closer to them helped with motor learning and agility versus the things that were further away from them. Experts with things that were further away from them still did well, and they benefited more with those distal foci. With regards to this term, this is goal-action coupling. So if we go back to the three terms we've covered already, autonomy, enhanced expectancies, and external focus, through the term goal-action coupling, this is the synthesis of all three of those points into the treatment method, what you're introducing with the patient. So ultimately, you can see that it takes the self-focus off of the patient, and it increases their focus on the goal or the task or whatever they're trying to achieve. And what they found is that when you shift your focus from off of yourself to the goal that you're trying to achieve, they've shown improved demonstrations of improved motor performance and motor learning. So what Wolf and colleagues continued to find out was, you can see incremental improvements in performance seen when you introduce just one aspect of these principles. But obviously, two factors through the research was shown to have a more incremental impact than one factor, and three factors versus two factors. So it's ultimately recommended that we try to incorporate all three of those factors in our interventions. We're going to talk about some of the research now, both including optimal theory, neuroplasticity, and its relevance to some of the populations that you may see, whether you're in an inpatient, outpatient setting, outpatient neurologic specialty setting, outpatient orthopedic specialty setting, and you can get a sense and see a feel for how the things we talked about today can work into them. So this was an article by Chua and colleagues. You'll see Wolf and Luthwaite are in there too. They were the ones who coined the optimal theory. The article is titled "Choose Your Words Wisely, Optimizing Impacts on Standardized Performance Testing." So what they looked at was the BEST test. It's called the Balance Error Scoring System. And that's a balance test in physical therapy where you're standing on and off of a compliant surface, a foam pad, with your feet positioned in a couple different areas. So you have a progressively narrow, more difficult base of support while your eyes are closed. So that's what you'll see with these, the two diagrams here. This was their results drawn from their study. And what they basically did was taking the optimal approach to patients, they showed that if they gave patients the option of choosing what portion of the test that they wanted to pick first, and they also gave them the enhanced expectations of telling them that research has shown that people their age do well with this test. They've shown that with their BEST score, which is their Balanced Error Scoring System score, the number of errors were fewer in that case with the optimal approach of the language that they used with these patients versus just the standardized language, not giving them the options to pick what portion of the test they were going to start with. When we look at the bottom table here, this is their center of pressure velocity, so their postural sway. It also showed that their postural sway was less. So giving them phrasing these forms of assessments when we talk to patients, and we kind of introduce, whether it be a balance assessment or 5 times sit to stand, a timed up and go. When we give them these instructions, it might be in our best interest to consider giving them options in how they want to approach the test, because it might improve their buy-in into the test, and it might ultimately bring the best function out of them because they feel like they have better involvement with the test. When we talk about life after brain damage, I went back to brain damage and stroke multiple times today. these were some discussion points that I wanted to bring about just for consideration. With neuroplasticity, we talk about it being present in, a healthy brain. It's important to realize that, after a traumatic brain injury, that's the most important point more than ever to incorporate some of these neuroplastic principles as well as the optimal theory. And this ties into from a rehabilitation standpoint more than a compensatory standpoint. When we look at rehabilitating these patients, there's a certain recovery timeline that we try to see and perceive and characterize and make sense of positive improvements with them. So it's important to consider those adaptive versus maladaptive changes and the influence that interference may have on their recovery. This was the clinical practice guideline published by Hornby and colleagues in 2020 on guidelines for improving function following stroke, spinal cord injury, and brain injury. And what I wanted to point out here was the specificity and intensity of training for the recommendations that they provided. So with this CPG being specifically focused on locomotor training, the interventions that they really recommended should be performing was walking, obviously, but at higher intensities. And they gauged these higher intensities based on a patient's predicted heart rate, maximal heart rate. So they were looking between 60 to 70% of their maximal heart rate. And they really recommended over ground walking versus body weight supported or light gait walking. So obviously more specific and more transparent to them. This is the clinical practice guideline for Parkinson's disease. And you can see again with their recommendations, they have a lot of great recommendations in here, but it's all task specific and geared towards balance and function, which specifically address a lot of the impairments that we see with patients with Parkinson's disease. When we look at task specific training, you can see that they recommend physical therapists should implement task specific training to improve task specific impairment levels and functional outcomes with individuals with Parkinson's disease. When we go back to that picture of the DTI fiber tractography, I think something that points out to me in my mind is, the impairments of patients with Parkinson's and the pathways in their brains is if we can tap into other emotional pathways to help them with motor learning, that may be beneficial as well. This is another article that was published regarding multiple sclerosis. So it goes back to highlighting the intensity and specificity of training for balance and walking. You typically think with patients with multiple sclerosis, we want to be mindful of their fatigue levels and fatigability, but it has been shown to be relatively safe in progressing them from an intensity standpoint. And then lastly, with regards to sports here, with more research done by Wolf and colleagues, this was internal, external cues that they looked at and their efficacy with people who were just learning golf for the first time. They weren't very experienced with golf. So they demonstrated here that those patients or those subjects that worked with external cues on their swing, focusing on the positioning of the club and the club face versus actually their arms, they demonstrated a higher target accuracy when putting and or swinging to a specific target than those with internal cues based on their arm rotation, their arm positioning, as well as the control, which just received a standard set of instructions. And lastly today, I wanted to touch on an article published for those with geriatric populations, which are more prevalently seen in any setting that we're in. They showed that optimal learning works well with patients with older populations too. In this study, they gave patients a certain stepping balance exercise intervention, and they gave them the option of picking what color they wanted the markers to be, what order and sequence they wanted to have them in, as well as positive reinforcement, so on their tasks. So highlighting the positive outcomes or the positive performances versus the negative outcomes. and they looked at each one of the components of the optimal theory again, and they demonstrated that there were improvements in performance in the patient's participation in the interventions, regardless of what portion of the optimal theory was used. I wanted to wrap up with some points to think about and reflect on today. You know, when we talk about neuroplasticity, I've had a large success with capitalizing and considering people with what their life context is, what walk of life they're coming from, and trying to understand from that standpoint, put myself in their shoes, you know, what they're thinking. And, you know, in that sense, I'm able to sort of use motivational interviewing to bring about, you know, what goals they're focused on. I've also had a lot of good successes using music as a motivator and improving patient investment in sessions. So I wanted to ultimately wrap up with what, you know, be mindful of what your patient is telling you, and prioritizing and addressing their concerns first can go a long way. Thank you for joining me today. Any questions? Okay, I'm now going to turn over to Dr. Lamm, presenting on movement science of disc golf.
And we'll have time for questions at the end.
All right. Thank you, Dr. Fischer. I like that you touched on golf there. I thought that was very appropriate. Thank you to everyone in attendance in person and to everyone attending online. I'm very excited to share this presentation with you, as it is something that I'm very passionate about. And I'm hoping that each and every one of you can hopefully take away something from this presentation and maybe apply it to your clinical practice. Did I begin? So our objectives for today, we're going to obviously define disc golf and discuss the history and growth of the sport. We're going to discuss the various throwing mechanics used in disc golf. We're going to discuss various disc golf injuries, prevalence, and anatomical locations. We are going to compare and contrast disc golf to traditional golf and ultimate frisbee. And we're going to discuss the clinical components and considerations when evaluating and treating disc golfers. So a little bit about my disc golf experience. Dr. Karahad touched on this earlier when he gave our backgrounds, but I've been playing for over a decade now. I'm involved with various clubs and organizations in the Lehigh Valley. I have been competing in amateur and pro tournaments and leagues since 2020, and I myself have treated several disc golfers with a whole variety of injuries: shoulder, ankle, hip, low back, just to name a few. We'll get into a little bit more about that in the later slides. I also have numerous friends and competitors who are currently playing through an injury and pain, and I've also developed a preliminary disc golf injury prevention screen with my colleague, Dr. Matthew Johnson. So, what is disc golf? For those of you that don't know, disc golf is played similarly to traditional golf, but instead of using a ball and clubs, we use a disc. So essentially, the disc is a more compact frisbee. It's not like a traditional frisbee that you throw for fun, or with ultimate frisbee. The disc is more compact, and there are different types of discs. There are drivers, fairways, mid-ranges, and putters, all with different designs to fly a specific flight. And then the golf hole in disc golf is actually a basket and chains that you're trying to get that disc into as many few strokes as possible. Just like with traditional golf, you try to get as few strokes as possible. A little bit about the disc golf history. How did this come to be? Well, the father of disc golf, Steady Ed Hedrick, patented the modern day frisbee, or the disc, in 1966. And he also developed the disc golf hole in 1975. Steady Ed founded the PDGA, which is similar to the PGA in traditional golf, in 1976. And that is the organization that members and competitors use to compete. And for example, my PDGA number is 144975. There are currently over 277,000 PDGA members and counting. So disc golf growth. This is data collected from UDisc, which is the popular app used for disc golfers to keep track of their scores and to find local courses, local leagues, tournaments to compete in. And in 2024, 2023 rather, they found that 1.4 million disc golfers were using UDisc in 2023 to keep tabs on their scores and compete in tournaments and leagues. And over 21.9 million rounds were scored on the UDisc app in 2023. I just think that's remarkable. Another very, very interesting fact about disc golf today is that the #1 free-to-play course in the world is actually right here in Pennsylvania. It's Fairleigh Lake Disc Golf Park in Beaver Springs. It is currently number 14 in the world to play overall, but is #1 free to play. So the 13 courses that are ahead of this course is obviously pay to play. So if you ever get a chance in Beaver Springs, go check out the #1 free to play course in the world. Again, with some of the disc golf growth, the number of courses at schools and universities are growing, and they grew by 20% in 2024. There's certain statistics about how many disc golf courses there are at public parks, schools, universities, camps, ski resorts, breweries, and wineries even. And here are a few on the sides of our local schools, universities that are currently having an active disc golf course. Again, with Bear Creek and Blue Mountain ski resorts and Long Trout Winery. So let's get into some throw types and grip styles. The most commonly used disc golf throw type is the backhand. That's one we're going to be focused on mainly today just because it is so common and prevalent. There are also forehand throws or the sidearm. There are overhand throws, which are like hammers and thumbers. The disc, obviously being spherical, you can also roll the disc. So there are also rolling throw types, backhand and forehand. The grenade is a backhand throw style, but it flies like an overhand throw. So it's a little bit more complex. And then there are various putting styles and grips as well. So you can spin the disc, you can push the disc. There are countless different putting styles and grips, but those are the main two. So here are some images that I took of the most common grips in disc golf. So this is going to be the backhand throw, the traditional backhand grip, also referred to as the power grip. As you can see, the thumb is on the top of the disc flight plate, and then the fingers are wrapped within the rim of the flight plate. And that allows for the maximum torque and power into the throw. For the forehand, and also as the hammer or the overhand throws, there are going to be similar grips there. The thumb is still going to be on the top of the plate, but then your index and your middle fingers are going to be on the rim of the disc to allow you to flick the disc as if you're throwing like a sidearm or you're throwing like a little baseball throw. And then common grip for putting, and then the thumber, which is another overhand throw, are pictured here as well. The thumb is on the flight rim for the thumber, and then putting fan grip allows for more control. So versus the power grip for when you're throwing for maximum distance, you have the fan grip for when you're going for a shorter, more controlled putt or throw. So now we're going to get into the backhand task analysis. So here's a nice overview of what the backhand mechanics should look like. We'll dissect each of those images one by one. So first and foremost, we have our preparation phase. This is where you line up your shot. You're going to line up to the basket or point in the fairway. You're going to set your grip and you're going to commit. Next, you get into what's called the X step in disc golf. So the X step, or also known as the crossover step, is now we're starting to shift our momentum towards our target. So our lower body movement is generating that momentum towards our target. And this is where the coordination and timing is going to be key to allow us to smoothly flow through the rest of this task analysis of the backhand throw. So that second step now, I'm going to go back and forth. how we are starting to coil our body. We're starting to load away from the target. So we're still generating that forward momentum. I'm still moving forward, but we're also going to start rotating. So we need that thoracolumbar mobility. We need that hip rotation. That's going to be key to allow us to coil and develop that potential energy into the throw. And then the third step of that crossover step, again, I am just continuing to coil here. The point is to coil, rotate, generating that potential energy. Requires that timing coordination. Dynamic balance is going to be key, especially when you're on uneven terrain. So disc golf can be played in all sorts of terrains, even in snow, icy conditions, gravel. So that dynamic balance is going to be key for this part of, again, just continue to coil and rotate using our obliques, our glutes. And now we get into what's called the reach back, which I think is a little bit of a misnomer, because when you think of reaching back, you think of using your arm to actually extend. But in reality, our arm is supposed to act more of like a whip. So your body is essentially moving around the disc, or that it should move around the disc, versus your arm having much involvement with this step of the backhand. This is where a lot of novice disc golfers can get injured because, and as I'll get into later, they use their arm more than their lower body and their core, so their obliques and their hips, to actually generate the power needed to throw the disc. So that's something we'll get into a little bit later. But again, you just want to think about moving your body around the disc, letting the arm be loose, acting as a whip, and this is the final loading of that energy before we're transferring into the disc. Now we're getting into the power pocket. So this is where all that stored potential energy that we coiled up through these first few steps can now be unleashed into the disc. So I want you to think of, as you're rotating, that movement brings your arm, which is the lever, which is supposed to act as the whip. It is coming tight to the body. Everything is coiling up. And you can think of your dancers out there or your baseball players out there, how you're just coiling into a nice tight position, so that way you can increase your angular speed, momentum, generate that torque, and that way you can transfer into the disc. Again, the arm should be just nice and relaxed, and your lower body, your obliques, your glutes are what drives this energy into the disc. Then we get into the release, the cracking of the whip, that I like to call it. It's to transfer energy into the disc, and then we get into our follow, which is arguably one of the most important parts of the throw. Again, where I see a lot of novice disc golfers get themselves into trouble is when they don't follow through properly. They don't get their entire bodies rotating through. Oftentimes, you'll see novice disc golfers go from this position, and then they'll stay where they're in the picture, the hips and the legs are, and the arm just kind of slingshots right through. So that causes a lot of stress onto the shoulder there. That follow through is something that you definitely want to keep an eye out for if you ever encounter a disc golfer in your clinic. So some key points that I've touched on: let that arm act as a whip, okay? You're supposed to utilize the lower body, the core, your hips to generate that torque and that power to then crack the whip and transfer that energy into the disc. Rotation is crucial, so looking at hip, thoracolumbar mobility and stability is going to be key for these athletes. And again, like I talked about, the follow through and deceleration is going to be key for that injury prevention, as well as looking at dynamic balance as disc golf is played on various terrains and weather conditions. I have countless patients who actually injured themselves because of poor dynamic balance, slipping, falling, then that leading to injury as well. So that is a key component to keep an eye out. So what does the literature say about the most common disc golf injuries? There are very few studies, but the few that I've found, Nelson and colleagues, found that their demographic was mainly 25 to 44-year-olds. However, there are all ages. And individuals that played more around 2 to 3 times per week, so someone who gets out on the weekends, were the bulk of the demographics for this study. So just keep that in mind. 20, 22, 25 to 44-year-olds, 2 to 3 times a week. And the disc golf injury occurrences that they found in this study were, not so surprisingly to me, but maybe surprising to you, were the shoulder, the elbow, back, and the knee. More emphasis on the upper extremities, the shoulder and the elbow. Kind of like I touched on earlier about during the throw, lacking that follow through, and then using their arm versus their entire body to generate that power into the throw. And again, Nelson et al. Found that the injury types were sprains and ligaments, ligament tears, strained pulled muscles, tendonitis, and unknown and other were the bulk of the injury types. And then here's another chart that I liked that broke down backhand throwers versus forehand throwers. Again, you can see that the majority of the individuals were backhand throwers. But even so, looking at how the shoulder and elbow were the main injury locations or anatomical locations versus all other areas. Again, with the lumbar spine, the low back, and the knee and ankle also taking some of that as well. So, what did disc golfers say about their injuries and their impact on their daily lives? Well, as you can imagine, those injuries that they sustained in disc golf affected their ADLs, affected their work, affected their ability to participate in recreational and sporting activities. And this is our bread and butter, right? Like this is what we get after as physical therapists and as healthcare professionals entirely. We want to help people get back to doing the things that they love to do and being able to do their daily activities without any pain or functional limitations. What % of people received treatment? The bulk of individuals in this study actually received no treatment. Now, you're probably thinking to yourself, why didn't these people seek out any sort of treatment if they're injured and they're impacting their daily living and their work activities? And disc golf is sort of a community that is generally lower socioeconomic status. Is a very affordable sport, so those individuals that are playing potentially may not have access to health care. So we just got to keep that in mind when we do get a disc golfer in our clinic. A bulk of these individuals usually don't seek treatment, so we got to treat these patients with respect, care, and making sure that we give them the best care possible. Robick and colleagues was another study that looked into disc golf injuries, and they found similarities. The shoulder and elbow were sort of the main culprit, and they also found that these individuals did not seek treatment, the majority of them, 50%, with injury duration lasting majority less than or equal to 1 month, but there are instances where those injuries went on to be chronic in nature. And I thought this was a very nice paragraph from that study, which essentially boiled down to, the lack of appropriate biomechanics were what led to injury in these athletes. Throwing with arm instead of transfer of energy. And again, we see this in novice disc golfers. The article says right out that it could be due to suboptimal kinetic chain, forcing players to increase force generation in the relatively smaller segments of the shoulder and elbow, rather than using their lower body, their core, their hips to generate that momentum into the throw. Something to be aware of. So now let's take a look at how traditional golf compares to disc golf in regards to injuries. So Moon and colleagues found that there were a large number of upper extremity injuries, but the bulk typically being with the lumbar spine, the spine in general, the trunk and chest and ribs. So if you kind of lump spine, lower back, trunk together, that made up the majority, but however, there were upper extremity injuries involved with traditional golf as well. What were the causes or mechanisms for why traditional golfers were injured? Typically it's from overuse, so too much play or practice, poor swing posture, over swinging, over twisting, things like that. However, then Moon and colleagues, Robinson and colleagues, Hasley and colleagues concluded that the majority of injuries in golfers, traditional golfers, were spine or lumbar spine, low back, along with the upper extremities. So the difference between disc golfers and traditional golfers up until this point with the evidence that we have is that disc golfers tend to injure their upper extremities more, meaning their shoulders, their elbows, as well as their back and knees, whereas traditional golfers are more likely to sustain spine injuries, lower back injuries versus their upper extremities. And the mechanism for disc golfers being inefficient biomechanics, and then traditional golfers being more overuse, just playing a lot. Now we're going to get into ultimate frisbee versus disc golf. The reason I wanted to compare these two is because a lot of people would come up to me and say, oh, you must be good at ultimate frisbee if you play disc golf, and vice versa. Well, actually, ultimate frisbee is played a lot differently than disc golf, and we'll get into that. The greatest injury location anatomically for ultimate frisbee athletes were actually lower extremity injuries. You're probably thinking, how is that possible? If they're throwing frisbees, wouldn't they potentially get an upper extremity injury or spine injury? Well, Fajardo and Peludo found that the lower limbs were most likely to be injured, and that probably has to do with the demands of ultimate frisbee being played more like football and lacrosse. There's the risk of contact injuries versus disc golfers and traditional golfers obviously not getting into any contact with any other individuals. So that's where the big difference comes in. If you ever have a disc golfer or an ultimate frisbee athlete, I don't want you to think that just because they involve a frisbee-like disc, that it's going to be similar in comparison to the injuries. They're completely different sports, completely different mechanisms for injuries. And again, those injuries resulting in musculoskeletal injuries. You could have ligamentous injuries. You could have superficial skin abrasions in ultimate frisbee there. Again, here's another chart talking about that as well, non-contact versus contact injury. This is a very neat graphic that they used in their study, Hess and colleagues, that they found, again, 72% of injuries in ultimate frisbee athletes were the lower extremity versus the upper extremity in disc golfers. And again, talking about the musculoskeletal nature of the injuries, ligamentous sprains, bruises, hematomas, muscle cramping. You're not going to find muscle cramping or bruising traditionally in golfers and disc golfers. Could happen potentially if they fall. And again, more evidence to show the lower extremities being the culprit. So I think we beat that horse enough. The summary: ultimate frisbee versus disc golfers. Disc golfers are going to suffer more upper extremity injuries versus ultimate frisbee athletes are going to suffer more lower extremity injuries. So ultimately, why should you care? The reason you should care is because disc golf, whether you like it or not, is going to continue to grow each year. People are going to be playing it. People enjoy it, and it is affordable. So a lot of people can go pick up a 3-pack of discs from their local sporting goods and get that for $20, and they can go to their local park and play for free. It's as simple as that. It's very affordable, and as it continues to grow, there's a higher chance that those individuals could be injured and show up in your clinic. And I even want to mention that there have been cases where athletes sustain a disc injury to the head just by being in proximity to the course. So potentially even a neuro PT could encounter a disc golfer if they sustain a concussion. So be on the lookout for that. And again, you should care because we want to be better equipped to treat all of our patients. And if this patient population comes through your door, you want to be able to handle them with the proper care as possible. What should you look for? All these things we kind of touched on throughout. You want to look at their mobility, look at PNF patterns. It is a transverse plane movement as well as moving through other planes. So you want to look at that. I know that can oftentimes be missed, is that transverse plane, but make sure to really look at that. Look at mobility. look at neurodynamics. Do your upper quarter screens, lower quarter screens. You never know if you're going to find maybe their source of pain coming from a spinal source. So always be aware of that. You want to look at force production, motor control, strength, power in all planes. You want to look at their task analysis. We kind of broke that down today. Make sure that they're engaging their lower body. Make sure they're engaging their core musculature, their hip musculature, versus just whipping with their arm. That could save somebody from potentially injuring themselves in the future. And we kind of talked about dynamic balance. You could be playing on all sorts of terrains. So ensuring that they have good dynamic balance so that way they don't fall when they go to throw. And that could lead to other injuries. And then they can also sustain a head injury as well there too. So, not just in an orthopedic setting, but they could end up in a neuro setting as well. And then I just want to share with you the preliminary injury prevention screening that I developed with Dr. Matthew Johnson. This is a nice tool to use if you ever have a disc golfer come into your clinic and you're just thinking, I don't even know where to begin with this person. Please feel free to reach out to Dr. Johnson or myself. We would be happy to share this with you and help you through treating that patient if need be. But yeah, don't forget about the task analysis and biomechanics as well as just those objective measures. My references, and thank you for listening. Any questions, any concerns?
Any questions, please either type into the chat or unmute yourself, or if you're in person, just ask. Louder so everybody can hear and voice.
Oh, you got it. Okay. George, you had mentioned that neuroplasticity could impair learning. Can you just expand on that for me a little bit so I have a better understanding by that?
Yeah, so you can see, call them maladaptive changes to basically how people do different things. So from my standpoint, if you have pain, right, you're going to probably move differently than you have prior to avoid that pain.
And that compensatory pattern is a neuroplastic change. I understand that correctly?
It can be.
I actually have
It sounds like, all we're getting, one of our basic principles I preach to the public and our materials is treat the injury early, get it early. That's, as soon as we can intervene, do our intervention, less likely for the maladaptive change. Many mobilities here. That principle seems to apply, which is neuroplastic principle that you're speaking. So powerful. And I kind of understand it, but not like walk.
I think and having been in the neuro PT realm of things, practicing for the last couple of years, it's aspects of our care that we routinely involve, but we don't think about it as much or as well in this context. So I think they did a great job of making that more finite and making it almost more tangible, if you will, kind of highlighting these principles. So. Yeah.
I also have another question for you, Fischer.
Sure.
So you mentioned a number of times throughout your presentation how what the words we use affect the patient and the patient's belief system and what they're coming in understanding about their injury impact neuroplasticity. Are you aware of any literature that looks at the effect of therapeutic alliance on neuroplasticity, either pro or con?
I'm sure there's literature out there. I'd have to look into it more. I think that's a great avenue to consider, especially from an alliance standpoint. You're talking about interprofessional relationships. Yeah, I'm sure that literature is out there, and I'm sure there's obvious opportunities to be had, especially on the therapeutic forefront between physical, speech, and occupational therapies.
mentioned a number of different extremity you need to look at the body.
Mhm.
One issue that I've come in contact with, especially with people, a lot of either running or tennis, people seem very resistant to stopping the activity for long periods of time.
Mhm.
So how do you manage a patient who doesn't want to stop the activity
Mhm.
completely, to let their body heal? How do you manage that type of situation?
Oh, I think that's a great question. And I get that all the time. My key is if it doesn't hurt, do it. And if you can dial back the intensity, do that as well. I tell people if they're having pain throwing full power or full speed, then maybe just stick to putting, stick to throwing more controlled shots, and stick to throwing, at an intensity level that does not cause pain or discomfort. I am not for one to just shut someone down completely if they're injured. I like to modify as I can possible. So I think short answer is modify the activity to make it not hurt, not reproduce symptoms as we continue to address any lingering deficits or form or mechanical issues, and then gradually reintroducing those higher intensities. Yeah, I think it's a great question that happens all the time.
Other questions?
One question.
Yes.
Maybe this would be out of curiosity.
Mhm.
To me, that seems like that'd be much more harm than whenever I look at like the injury rate. So
Yeah.
if it was somebody versus backhand throw, also do a lot of like.
Absolutely. So the mechanics, I know I didn't really get into that because it is not as common as the backhand, but the throw in general does also incorporate a lot of lower body, a lot of hip and oblique momentum. And you're also with like a forehand throw, you are still trying to keep the disc close to the body. So that way you're using more of that rotation versus more of an arm throw. There are individuals out there who were previous baseball players who get away with throwing with just their arm due to having that experience. But from my experience, it does also incorporate a lot of core hip engagement, a lot of lower body engagement as the backhand throw. So I think that's a great question. Yeah, I think forehand definitely.
If you have any further questions, please feel free to reach out to either Dr. Fischer or Dr. Lamm. And thank you very much for joining us. Please make sure you complete the quiz and the evaluation to get CE credit. And if you have any questions, please reach out.